One of the questions we get asked frequently is, why does the IOP value from this device differ from the IOP I'm getting on my Goldman tonometer or my other method of tonometry? So let's talk about that for a moment. The IOP-CC measurement, if you recall, is specifically designed to be less dependent on corneal properties, so it's reasonable to expect that that pressure measurement might read differently from Goldman in a large percentage of cases. So let's talk about the IOP-G measurement, however. The IOP-G measurement is supposed to be essentially a Goldman equivalent, and dozens of clinical studies have concluded that the IOP-G measurement from this device is highly correlated with actual Goldman tonometry measurements. But correlation does not constitute 100% agreement. In fact, no two tonometers will ever read exactly the same on any particular patient's eye in all cases. So if you see small differences between this IOP-G value and the Goldman measurement in your practice, that should be considered normal. And you would expect to see that this measurement will agree with Goldman tonometry plus or minus 2 or 3 millimeters of mercury in a large majority of cases. Now, there's always going to be some examples where this device doesn't agree with the Goldman, and it might be by a considerable amount. And that's usually attributed to perhaps postural changes in the patient. Don't forget, Goldman is a very subjective method of tonometry. Two different Goldman operators will give you two different answers as to what the pressure is in any particular patient's eye at the same point in time. When a patient moves positions, changes rooms, there's lots of different variables that come into play here, lots of opportunity for actual pressure changes to occur. And also, no two tonometers are affected by the cornea in the same way, and there's instances such as corneal edema, as an example, where the Goldman tonometer is going to significantly underestimate the pressure, and our IOP-G measurement just doesn't behave in the same manner. So, if you're seeing differences between IOP-G and Goldman tonometry in some patients, even if it's a large disagreement on occasion, that should be considered normal. If you're seeing an offset, for example, if your Goldman's always 4 millimeters higher than the IOP-G or 4 millimeters lower than the IOP-G, and it's happening in the vast majority of your patients, well, that's unusual. The direction of the agreement or disagreement between Goldman and IOP-G should be quite random, and it should also be fairly small in most of your patients. So if you're seeing an offset, if you're seeing a large offset between IOP-G and another tonometer in your practice, perhaps one of those two devices needs calibration or service. If you suspect it's the ocular response analyzer, call Riker Technical Support and we'll begin discussing the best way to address that concern for you. Another frequent question we get is related to asymmetry between the two eyes, particularly with the IOP measurements. Some people will say, well, I always get the same value in the two eyes on my patient with a Goldman tonometer, and with this device sometimes I get 2 millimeters of difference, 4 millimeters of difference, 5 millimeters of difference between the two eyes. Why is that? The answer is twofold. First of all, it's important to understand that this measurement happens very rapidly. The measurement is over in 25 milliseconds. And this is at random to the ocular pulse. So every time the heart beats, there's a small pressure change in the eye. On average, that pressure change is about 2.5 millimeters, but in some patients, it's as high as 6 millimeters. So it's possible if you measure one eye and then measure the other eye, that you catch one eye at the peak and one eye at the trough of the cardiac cycle, and this can cause an actual pressure change. And because this measurement is so rapid, it captures that actual pressure change. So you're looking at a difference that really occurred due to the ocular pulse. If you think this might be the case, go ahead and make multiple measurements, and the intelligent averaging system should average out those ocular pulse-related pressure changes. Another possibility is that, remember, Goldman is subjective. The clinician decides what the pressure is with a Goldman tonometer based on their experience and their technique. But two different Goldman operators are going to give two different answers in many cases for the same patient eye at the same point in time. And so when you measure a patient with a Goldman tonometer and you get 16 in one eye, guess what the pressure is going to be in the second eye? So this subjectivity of Goldman tonometry has lulled clinicians into a false sense of IOP symmetry between the two eyes over the years. But what we've learned in recent studies, including implantable pressure transducer studies in primates and other things of that nature, is that the intraocular pressure fluctuates much more dramatically and also very rapidly than we have previously appreciated. So it's not unlikely to actually have a pressure difference between the two eyes. Could be related to the ocular pulse, or it could actually be a pressure difference between the two eyes. Look for good waveform scores, and if you see an asymmetry that's concerning to you, make multiple measurements to try to average out those pressure fluctuations. If you wind up with a 4 millimeter difference between the pressure in the two eyes, that's what it is.
Since introducing the original non-contact tonometer in 1972, Reichert has led the market in tonometer innovation and established itself as a pioneer in corneal biomechanics and corneal hysteresis. Reichert Ocular Response Analyzer G3 Auto Tonometer with corneal hysteresis, proudly made at our world headquarters in Buffalo, New York, USA by Reichert Technologies.